Um, Mr. Chairman, ladies, guests, and fellows, I would like once more to acknowledge my gratitude for inviting me to this distinguished Congress. My topic would be surgical treatment of craniocerebral fractures, uh, motion sparing techniques for the most demanding cases. Uh, we have to start with the statement that cervical spine fractures occur in up to 3% of trauma cases. They account for two-thirds of spinal cord injuries, and especially injury to C1, C2 complex accounts to up to one-fourth of cervical spine injuries. And fractures, among them fractures of odontoid peg, C2, occur most frequently, contributing to 55% of those patients. There are three types of fractures which you already know, and it has been mentioned and discussed before yesterday during yesterday's session. And we have to say that C0, C1, C2 is a complex bony joint ligament system which is responsible for half of a range of head and neck movement. This is very important because first, Atlanto-occipital junction is responsible for 50 degrees of a range of head and neck flexion, while the Atlanto-axial C1, C2 junction is responsible for half of a range of head and neck rotation. So our task is to spur this movement whenever it's possible. Every method of C0, C1, C2 fracture does should aim to preserve the motor function and should take into account vectors of the strongest acting forces, the vectors of flexion, rotation, and the gravitational vector. So I would make a title of my presentation in Pursuit of Motion Preservation, and I would add tips and tricks of the treatment. Existing methods of C0, C1, C2 fixations are better self-compressing screw fixation, one or two screws. Usually it doesn't matter if there are one or two, but I will show later on the very special cases in which there is an obvious prevalence of two screws fixation. Then we have Magel procedure, Harms procedure, so-called V fixation, C1, C2 transarticular fixation, and of course medical treatment alone or semi-instrumentation, hollow immobilization. So we have to say that Magel procedure, Harms procedure, and V fixation do not preserve C1, C2 rotation. Usually odontoid screw fixation preserves C1, C2 rotation. The tools are well known, and the technique is well known and well described, but there are some problems which are sometimes unusual. In some patients, postoperative neck bracing and immobilization is not possible for a series of reasons. Well, first, I would like to present a case of 25-year-old man with a history on non-compliance with postoperative medical recommendation in the past. Non-compliance is a very important factor contributing to the future of the patient. This young boy has passed a car crash accident 1 year prior to this hospitalization, and then one of his kidney has been removed. It was due to the fact that he did not close the safety belt in his car. So he was set to do so in the future, but he never done. And so 1 year later, he came to our department after a car crash in which he was the victim, and he did not comply with the recommendations, medical recommendation. Again, he did not close his safety belt. So we anticipated he will be not compliant patient in the future, and so we thought to do something to cope with his non-compliance, and this was his case, the type 2 odontoid fracture, and we have to split the gravitational vector into two forces. One is shearing force, and the second is compressing force, and it's obvious in this case that the shearing force is much higher than the compressing force. So we have to create so he preoperatively he had full range of rotation and full range of flexion. So aim of the surgery was to fix two screws to create not one screw, but two screws to create a plate which will be resistant to create a plane resistant to both rotation and flexion forces, and especially this very strong shearing vector. So we placed these screws in a plane. They were directed obliquely like this. It should be stressed that in this case, even in a very narrow odontite pack, with this direction, oblique direction, we have the possibility to put two screws and within the sponge's bone. And this is the postoperative. Postoperative scan and X-ray, and we are able to achieve a good fusion 2 months postoperatively. And of course, according to our suspicion, the patient was completely not compliant, and he didn't wear this neck bracing even 1 hour. So he was completely moving freely, and despite this fact, the fusion was perfect. This is the postoperative control movie of this patient. I have to highlight that I'm showing the faces of the patient because I have obtained the informed consent for this written informed consent from these patients. So the range of rotation postoperatively 2 months postoperatively is normal, and the patient was not compliant with our recommendations. And the second very similar case, but with a different problem, was a 97-year-old woman. This is a problem of my country, the aging population, and this lady was in the 10th decade of her life. She nevertheless, with this age, she was self-dependent, and she has been taken to the hospital after fall in her home. And the problem was that neck bracing was not possible in this lady because the skin of this almost 100-year-old lady was so thin and was so irritable that she was not to tolerate any bracing material. So we have to think about something else. And well, it was another problem that this lady had a very strong sagittal imbalance due to Parkinson-like propulsion. So we have to cope with both non-tolerating any bracing, postoperative bracing, and we have to cope with the strong sagittal imbalance. So how to address this problem? We decided our choice was to put two screws, but in a very unusual way, and a sagittal plane in a row in AP direction to resist to the strongest part of this shearing vector, which was secondary to the strong sagittal imbalance. If we split this gravitational vector in this case, we will see that the shearing vector is very strong due to this very strong sagittal imbalance, Parkinson-like position of the body. So we put the screws like this in a row in a sagittal plane, and of course she did not wear any neck bracing postoperatively. This is the position of the screws on CT scan, and this lady. This is the X-ray, the CT Scout X-ray, and this is 2 months. 2 months later, MRI control scan, and this is 2 months later control CT scan. And this is the lady 2 months following surgery, where of course no fusion is present, but she is able to move. She's able to move. where she's able to rotate her neck to the premorbid range. I have to add that this lady has been seen on last follow-up check 3 years postoperatively, and she was then 100 years old. So even in such an old patient, the fusion is possible and the sparing of motion is possible. In both patients, double odontoid screws were placed in a specific directional, I would say non-standard manner, with the intention to create an enforced plane directed especially to resist the highest anticipated shearing screws. So so I will go to the last statement. The next problem is osteoporosis. Sometimes you cannot put the screw because of severe osteoporosis. This is a case like this. So we decided then to secure the odontoid screw with anterior plate, and it worked, and we were able to achieve the fusion even in such an osteoporotic case. And I would like to show something different. This is the last patient which I would like to show. This was the unsuccessful trial of medical treatment of C1 and C2 lateral fracture. So after unsuccessful medical treatment alone, we decided to repair directly this displacement and to fix the bones. And this was done with the short screws. And after short screws placement, we were able to achieve this position of this shape of the vertebral channel, and the screw fixation was successful. So after 2 months, we have observed the fusion, and the patient was able to rotate his head. Of course, sometimes it is not possible to preserve motion. These are cases like this in which it is not possible, so we have to give up, and then there are very few cases in which still it is necessary for fusion, but they should be as infrequent as possible. This is sometimes you have to do harm surgery like this. And one very unusual case in which of course motion preservation is not possible. This is the very unusual case of the fracture of the condylus, which condylus compressed directly medulla oblongata, causing the hand, the upper limb paresis. So sometimes you have to combine the techniques from skull-based surgery. It was a far lateral approach and direct removal, amputation, removal of the condylus, and this is the control CT scan after removal of the condylus. The patient recovered, and his head movement was perfect. But of course, we have to put the screws and to make a fixation in this case. And of course, sometimes you have to perform V fixation, which is also halfway of spurring and not spurring motion of this very complex junction. Thank you for your attention.